And we're now going to open up the Q&A to all of our speakers from our first morning evening session, depending upon where in the world and the hemispheres you may be. And I don't know, is Philip still with us from Australia? There was a question about what is the utility. Good, excellent, yes. Philip. You saw in the chat there was a question about what is the utility of the IBCM in your experience in Africa, and in particular in regards to Sierra Leone, please.
So Sierra Leone, we just proposed the integrated bite case management for Sierra Leone to implement. They are yet to implement. But if at all, one of the benefit is really to assist in risk assessment following dog bites to really ensure whether there's need to take post-exposure prophylaxis upon bite. So the Sierra Leone is here to implement integrated bite case management. They are here to implement it.
So as a follow-up to that, have you encountered marked resistance from any particular communities, either in Sierra Leone, in Western Africa, other parts of Africa, based on culture, religion, politics, personal opinions, etc.?
I think they really have been. There have been sporadic reports, really, of some cultural practices associated with some traditional treatment. But overall, I reckon if implemented, I think it will be accepted.
And do you think we should be eating dogs? And what's the role of dog markets?
Prof, I think we have, these are things that are beyond, there are certain things that are laid down in the culture. So it's really hard to stop some of the practices. The only way out is really to continue education and education. And also perhaps if we can adopt the polio model, during the, as you are well aware that most countries in Africa have really eliminated the wild polio. So basically through what we did, or they try to engage people, is to really show them that this is someone who has who was what do you call it, who refused vaccination, non-compliant to polio vaccination, and he was infected with polio, and this is how his state of health is. So by really engaging people, using people who have really come down with a particular disease, it's more likely that may drive people to stop some of their practices. So perhaps if we have adopt some of those strategies for rabies, it may go a long way. But it is really hard to stop people really from dog meat consumption.
Yes, and thank you for bringing in that concept of polio, and it's related in the rabies sense, in that recall that we had wished for the eradication of polio by the year 2000, and here we are 2 decades later, being close but not having reached that goal, and now see polio reappearing, unfortunately, even in places such as the United States. So it brings into context not only what's the importance of a term and a program, such as eradication, which we can achieve in rabies, but that doesn't mean we can't start doing something. Also, in regards to both Terence as well as Andy, we were hoping that you could share some of your thoughts and experiences as you've seen either on the Indian subcontinent or regionally in some of the other areas in Africa, Asia, and the Middle East. How does your experiences reflect to some of the other countries who are engaged, or perhaps not as fully engaged as what we've heard, such as in Asia, for example, Malaysia, Indonesia, the Philippines, etc.? Do you have any thoughts on how your opportunities that you've experienced may also be relevant to other areas that are deeply affected by rabies? Andy,
Yeah, I think
go
from
ahead.
my perspective, much of it is a practical challenge in implementation. I think, well, there's obviously political difficulties in prioritizing rabies and making the case for it, but it's all well and good having the scientific rationale, the political rationale, but implementation can be a real challenge. And I think that's where we've been learning and understanding the difficulties of implementation, and therefore trying to present governments with opportunities for success. You know, no government wants to embark on something that is unlikely to succeed. It's a huge political risk, and where there are limited examples that if they put their name to rabies control and embark on it and then it fails, no one else is going to take that challenge. And so I think presenting a scenario where they can see this is possible and achievable with their resources is much more than likely that they're going to embark on that journey with confidence. So I think absolutely it would be my short answer with the right tools and methods.
Terence?
Yes, I think I 100% agree with what Andy said, and I think hopefully some of that came through in my presentation in terms of the importance of sharing these lessons, these case studies, demonstrating that it really is possible. So we know that in many instances it's easy to generate a plan, but then, as Andy says, that implementation is often that stumbling block. And if you can show countries or even particular areas within a country that it is possible, that especially in terms of that competition between neighbors, we see that often within particular regions, or maybe in Andy's example, between different states, saying, they've done it, so why can't we do it? And I think identifying those champions on the ground who can really take the leadership and implement it is absolutely essential, because without those champions on the ground, we can support as much as we want, we can try to drive it as much as possible, but you need that person on the ground with that local knowledge, those local contacts, to then truly implement it.
Yes, for sure. Thank you. Wanda, are you still with us?
Yes, I am.
Yes, great. Thank you. I'm sorry, I don't see all the pictures of everyone concomitantly. You'll see that there was a question that came up, an interesting one, about not only the role of serology, virus neutralizing antibodies, duration of immunity in dogs, but also your thoughts on cross immunity of, for example, classical rabies vaccination and some of the other LISAs. Your thoughts? I'm sorry, are you muted? Sorry.
Can't believe I did that. If the dogma or the academic thinking is the more diverse the virus is, the less the rabies vaccine will protect, because it's made from a rabies virus backbone. What we do start seeing, and this is just in virus neutralization assays, is that it's not so clear that you can just do it based on looking at the sequence of the glycoprotein. And we do see with several of, phylo group 3 and then some of the new groups, which is the West Caucasians and some of those Lagos, we know there's no protection. But we even see that with some of the phylo group 1 viruses like Dibenauge, we struggle to get protection or to see virus neutralization in some of our systems. This is not in a challenged system. This is in virus nukes in a lab system. So there's a lot we need to still understand about cross-neutralization, I think. We basically focus on rabies virus, but we need to have a backup plan. And I think if we do make new vaccines, we need to think broader than just rabies virus. And if we need to make new therapeutics also. We tested our RIC in South Africa, and it's not protecting against all our diversity, even the ones we thought it's protecting against.
And so in regards to those particularly phylo group 2s and 3s, figuratively, that we don't have human cases, do you think that's blind luck, surveillance, pathobiological barriers? What are your thoughts on why we haven't seen, luckily, some human cases of some of these very disparate Lissa viruses?
I think surveillance may be an issue. I mean, if I speak on behalf of the African continent, we're mostly doing reporting of rabies cases based on clinical grounds. So nobody will ever go and type that virus and say it's a rabies-related virus.
Sure.
So there may be some underreporting, but I do not think we get a lot. And it's probably just a contact issue also. I mean, we're also not seeing spillover of bat viruses in South Africa or filoviruses because people don't have a lot of contact with bats. But in regions of the world where we have a lot of rabies-related viruses and lots of contact, immediately that risk becomes higher. And that is the regions where we don't have any data on human cases that's actually genetically typed. If we just look at how many encephalitic diseases are not being identified to the source, rabies can be part of that, and rabies related also. But I don't think all our energy should be in rabies related in human cases. But if we have an opportunity to include it, for instance, in new therapeutics and new vaccines, why not?
So from the standpoint of One Health, we do know we have had cross-species transmission from non-rabies lysas to domestic animals, even some of whom have had a history of vaccination. And so do you tend to see your spillover transmissions into cats as well as dogs, or do you think there's also some phylogenetic barriers, taxonomic, from the standpoint of these viruses and their potential hosts?
So we had dogs and cats. Mshelbwala, which is a virus that we don't know if it's a bat virus, most of our cases are cats. And the vaccine doesn't protect against Mshelbwala. So it may be just a contact issue, that it's maybe a shrew or something else where the virus is coming from. But it's definitely not the one or the other. We've got Lagos in cats and in dogs. We've had Mshelbwala in cats and in dogs, even in wildlife. So I think all mammals should probably be susceptible.
And so all domestic animals at risk of exposure should be vaccinated, I'm assuming.
Yes.
And what's the, since you mentioned the M word, what's the reservoir of Mshelbwala?
I think it's shrews, but that's also my opinion.
I agree with you. And all the rest of the speakers from this morning, we're curious, what challenges has the COVID-19 pandemic posed in regards to surveillance, education, prevention, or control? Anyone?
I think just from the international community, there's a recent publication from a research scientist at the World Health Organization that published the impact through a survey of COVID on rabies control. And I think, I'm assuming that everyone will agree, but in terms of the dog vaccination efforts, that was obviously severely impacted in terms of surveillance, and the redirection of resources away from rabies to address the other public health challenges is always a concern, whether it's with COVID or whether it's with any other new emerging or pandemic disease that does come about.
Yes. Andy, Philip, would you agree?
I totally agree with what Terence said in the disruptions operations as it was for across the board. We did see some interesting changes in the dog rabies incidence in Goa State during the pandemic. Obviously, vaccination had to stop for a period, but then was able to get going. But we saw an increase in cases around the northern area, and we can hypothesize that might be due to changes in dog movements and competition for food as their food sources were disrupted with COVID. So we don't have any hard data on that yet, but it may have actually impacted on increasing spread of rabies in some communities.
Philip, any thoughts from the West African perspective?
Yeah, I totally agree with Terence, because the limited resources that was really available for rabies was diverted to COVID-19. And also, as you are well aware, the attention is all over towards COVID-19. Nobody cares about the fact that people don't really care about animals. It also goes further to compound issues So I think I totally agree with Terence that attention has been shifted around rabies to COVID-19.
And do we think any of the vaccine hesitancy issues may also have application in regards to rabies prevention and control?
Not really. No, but there have been really there have been reports. I don't think so. No, not really. I don't think so. So long as vaccines are available, people are very willing to take for rabies especially.
You know, there is unfortunately one case from last year of an individual exposed in the United States who was exposed to a rabid animal. The animal was laboratory confirmed. The individual was consulted by public health about the dangers of rabies and individually elected not to receive prophylaxis and died of rabies.
Yes.
So where there's one case, there's probably others, and we hope that vaccine hesitancy does not bleed over into this disease, either for humans or other animals. Other thoughts from the rest of the speakers in terms of vaccine hesitancy? Andy?
Oh, not in vaccine hesitancy, but if there is one silver lining, obviously it was overwhelmingly negative, but as we come out the other side of the COVID pandemic, a legacy of it is the increased resource in laboratories, particularly for PCR and sequencing capacity, and that might be something that could be leveraged to support improved rabies surveillance. So I think if people have, additional equipment and there's an opportunity there with a bit of more training, perhaps for rabies virus sequencing, we should absolutely make the most of that.
And what about point of care diagnostics as well?
As regards to lateral flow assays, so that's a hotly contested subject still in the rabies community, I think, and the United Against Rabies Forum, I believe, are doing a systematic review of those particular devices. Personally, I'm a great advocate of their use for a screening tool in the field and giving vets the motivation to take a sample, even in areas where perhaps they're not confident they'll be able to get that sample to the laboratory. But nonetheless, we need those laboratory diagnostic tests anyway. So I think both are going to be needed at scale.
So I'll also ask for Terence's opinion, but while I have you, about the LAFAs and their role, I do agree they do have a part to play in regards to surveillance. We're curious, at least in terms of point of care and for field use, that you have a brain and you can make an impression on a slide, for example, for DFA or for DRIT. But now if you have this brain for linear flow, what are your recommendations as to how is that brain tissue made available for a linear flow in terms of, if we think of COVID and nasal or oral swabs, and now we have a brain tissue, how do you go ahead and apply that solid brain tissue for application to a LAFA safely by individuals who may not be vaccinated against the disease?
Well, I think absolutely anyone that's involved in rabies surveillance needs to be vaccinated, pre-exposure vaccinated as an absolute prerequisite. It's just a higher risk role for being
What a
exposed.
smart guy. He takes that question and he turns it exactly into what I wanted him to say, that everybody should be vaccinated with pre-exposure who's doing this. And so you have less of a concern if they're homogenizing a brain in the field without a biosafety cabinet for a linear flow assay. Is that correct?
Yeah, and the homogenization step is a concern, and people need to be trained carefully in how to do this and the risks and how to ensure that they're protected and made aware of what constitutes an exposure. We have to be realistic in what's possible in many of these places, and having a hood and everything just isn't feasible in the short term. So I think that needs to be carefully evaluated, and there needs to be more evidence around the risk that's involved, and that needs to be quantified.
Terence?
Yes, I mean, I fully agree. All personnel who are involved in rabies control and elimination efforts should certainly undertake pre-exposure vaccination and ensure that their titers are protective while they are active. I think
no protective titers, you mean they should be adequate? There are no protective virus neutralizing antibody titers, Terence. I understand.
Apologies,
what you mean.
yes.
No.
Adequate. But I think in terms of one of the comments that Professor Markotter just posted is that in the developing world, there is little pre-exposure prophylaxis that is available. We understand that many professionals just do not have access to this, even if they are the high-risk groups. And that is certainly a challenge that needs to be overcome. While, I think irrespective of the procedure that's taken, there must always be the proper precautions that are put in place. So the personal protective equipment, the proper protocols and the safety mechanisms around that to reduce your risk as much as possible while you are out in the field, whether you are vaccinated or not.
Yes.
Of course, ideally, you should be vaccinated. And then just touching on the earlier comments in terms of COVID, I think one of the strange silver linings is, I think, touched upon in terms of the understanding of the public about the importance of surveillance. I think now everybody around the world understands that what a positive case means, what needs to be done, why we think surveillance is so important. Why should you bother collecting all this data? When I think previously, especially in the rabies community, this was something that when trying to engage with the public or people who are working in local communities, it wasn't something that was well understood. And I think now after COVID, where everyone's reporting their results, they're doing these lateral flow device point of care tests, everyone's worried, well, are you positive? Are you negative? What does that mean? And I think that surveillance and that data collection is something that has really come through as I must admit, strange, but a silver lining, at least for rabies and all other diseases that we need to address.
And also for a limited time anyway, during the lockdowns, during the shelter in places, limitations in movement, there was perhaps another silver lining of a relative limitation of exposure to certain animals on the street, at least for a period of time. So other benefits that showing if you could minimize exposures, it also has a part to play as well.
Yeah, in fact, there's a publication stating about a severe drop in rabies cases in travelers because of the lockdown and the restriction of international travel. So again, as you say, some strange silver linings that came out of COVID.
And also, since we talked about the point of, unfortunately, fewer individuals having pre-exposure who should, we're also curious for the speakers who are still engaged, why has the concept of dose-sparing vaccination and PrEP, particularly focused in Asia, taken off, and yet we don't seem to have that same degree of application for intradermal vaccination in Africa? Any thoughts? Terence, Andy, Wanda, Philip?
I can maybe speak on South Africa's behalf. Our cases are not in one location. So
no clinics.
Yes, we've approved it now for use in South Africa. So we have that option. So if there's a lot of people being exposed and we need to vaccinate a lot of people at once, we will go for that option. But we use it now mostly in our pre-exposure situations, at least. But we, for instance, have one case in the one clinic one day, and then one case in a clinic that's 300 kilometers away. So then you sit with all kinds of issues of open tubes and quality that you don't really want to play around with. So that's our major issue around it.
So at a minimum, we should be using dose-sparing intradermal vaccination to have more individuals who are at risk to have pre-exposure, such as our animal handlers or veterinarians, etc.
We need to advocate that, because we recently had that discussion in South Africa, because we can vaccinate the whole veterinary services with only a few vials.
Exactly. Excellent. And particularly a place like Sierra Leone, where Philip said, I think there's only 12 veterinarians in the country. So with 2 vials, you can vaccinate all your veterinarians in Sierra Leone, Philip.
Yeah, just to comment on that, most recently when, there's this ongoing mass vaccination in some selected districts of Sierra Leone. So towards the start of the vaccination, we had several meetings. And one of the challenges really with the dose, intradermal dose pairing method is the fact that people are not aware of it. So when we proposed it, So they totally are not aware of it. So I had to send in some documents to show them that this is really evident. So I think in Africa, awareness also will play a key role, especially on the importance. So I think people are not aware. That is the main thing in Africa.
And I think, hence, very importantly, the attention and awareness and advocacy, because the concept of intradermal certainly is not new. It's been known and used effectively for decades. It's similar to our diagnostic tests, our understanding of pathobiology and epidemiology. We have all the, not to say that new tools aren't necessary, but we have all the tools we need for the implementation of the ZBT. And I apologize to the speakers for keeping you longer, and for the audience that we're a little overdue for our break.